Alrighty, guys. So it's 101. We will get started. So I just wanted to welcome everybody to today's webinar. It's Interventional Pain Management, Exploring Spinal Stimulators and Beyond. The session is hosted by Medical and Life Care Consulting Services. We're a Massachusetts-based case management and nurse consulting firm. We're so excited to have you join us for this discussion. My name is Dane Lekhavich, and I serve as the marketing director at MLCC. I'll be your moderator for today's Injury Insight webinar. The session is expected to run for approximately 50 minutes, followed by a 10-minute Q&A where we'll address your questions. After the webinar, we'll share the recording, presentation materials, and templates on our website under the webinars section. For today's session, we'll be covering more than just spinal stimulation, providing a broader perspective on various pain management modalities and techniques. To begin, I'd like to introduce our CEO, Cynthia Bourbeau. Cynthia Bourbeau is the president and founder of Medical and Life Care Consulting Services. She's a registered nurse, certified rehabilitation nurse, case manager, nurse life care planner, and legal nurse consultant with over 40 years of nursing experience. Since founding MLCC in 2001, Cynthia has led the team of professional nurse consultants and case managers, specializing in medical case management, life care planning, and other medical legal services. She's an active member of the American Association of Nurse Life Care Planners, a board member of the CNLCP Certification Board, and a member of the Association of Rehabilitation Nurses and the Case Management Society of America. With that, Cindy, take it away. Cindy, I think you're on mute.
Sorry about that. I'm having a conversation with myself. Thank you,
Yes.
Dane. First, I'd like to share a little bit about the Injury Insight program. This is a 4-part webinar series designed to educate claims professionals, human resource professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments, both common and uncommon, within workers' compensation. The program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnoses, the road to recovery, the potential obstacles, and answer your toughest of questions. So as always, get your questions ready. For this year's first Injury Insight session, Interventional Pain Management, Exploring Spinal Cord Stimulators and Beyond, we're pleased to have Dr. Sean Kumar. Before I tell you about him, I just want to say thank you to Dr. Kumar, who's, life is busy for all of us, but he's gone out of his way to give us this time so that we can share this information with you. And so a big thank you to Dr. Kumar for this. Dr. Kumar will guide us through a multidisciplinary approach that includes physical therapy, medications, injection therapy, and advanced interventions like spinal cord stimulation, focusing on restoring function and improving quality of life. Dr. Kumar is a board-certified anesthesiologist and interventional pain specialist with extensive experience in pain medicine and anesthesiology. He currently serves as the Director of Interventional Pain Medicine at St. Vincent's Hospital in Worcester, Mass. Dr. Kumar holds dual board certifications from the American Board of Anesthesiology in both anesthesiology and pain medicine. His medical journey includes a fellowship in pain medicine at Rush University Medical Center in Chicago, where he also held a faculty appointment as an instructor in the Department of Anesthesiology. Prior to his specialization in pain medicine, Dr. Kumar completed his residency in anesthesiology at Louisiana State University Health Sciences Center. Beyond clinical medicine, Dr. Kumar has a strong background in healthcare management, having earned an MBA in healthcare management from Boston University. His diverse experience also includes roles as a biotechnology and pharmaceutical industry analyst, a strategy consultant for Genzyme Corporation, and a technical project manager in healthcare IT. Dr. Kumar has been actively involved in research and professional organizations, presenting at national conferences, and contributing to advancement in interventional pain procedures. His commitment to patient care extends beyond the hospital, as you can see, because he's here today. But he also participates in outreach programs providing medical care to underserved communities. I think a great topic for maybe another webinar in the future, it would be on AI in medicine. I would love to get your information, your thoughts on all of that. So without further ado, I'd like to turn this over to Dr. Kumar to begin, and thank you again for being here today.
Thank you for the introduction and for having me as part of the program today. I wanted to use this presentation to kind of give you a high-level overview of the many minimally invasive options that exist to treat chronic pain. Although this presentation will primarily focus on spinal pain, I'll touch on some other pathologies such as complex regional pain syndrome and other issues that may occur, especially from workplace-related injuries. To start, I've prepared a brief overview of just spinal anatomy, so a lot of these procedures will make some more sense. The spine is composed of a combination of bones, flexible ligaments, tendons, as well as large muscles and nerves. The primary purpose of this system is to provide a structural pillar for the body, as well as to protect the spinal cord, as well as exiting nerve roots from damage. It has this task, yet it has to remain highly flexible, allowing movement. And this is what makes it a very complex system. If you look at the spine, there are four main sections. There's the cervical, thoracic, lumbar, and sacral regions. Although the overall structure and function of the spine is similar throughout the different segments, you can see that there are structural variations throughout the spine. And these variations reflect the different functions that each portion of the spine must support. For instance, if you look at the cervical spine, the vertebral bodies are smaller, however, the joints take up more of the function. And because the cervical spine has to support a little weight, it, however, has to have extreme ranges of motion. The lumbar spine, on the other hand, supports a lot of weight, but doesn't have to have the same range of motion. So you can see these changes in structure throughout this to support the function. In terms of this procedure, I'll primarily use the lumbar spine for illustration purposes. It's here that the vertebral bodies are the largest, and it's easier to kind of show the different parts of the spine here. On the next slide, you can see the various components of the vertebral bodies. This is a side view here, and then you can see it from the back on the right-hand side. And all of these components are basically there to help facilitate motion in the spine, as well as to protect and allow the nerves to have an area to traverse. On the next slide, you can see a cross-sectional image here. And this image shows the end of the spinal cord, which is called the cauda equina, passing within the spinal canal. One thing to note here is when you see these filaments coming through that canal, you can see there's not a lot of extra room here. This is something that we'll talk about as we progress in the presentation. Now on to the next procedure. This is the notorious intervertebral disc. And this is really what everyone thinks about when they think about spinal pathology. This is usually where the initial injury occurs. The best way to think of a disc is like a jelly donut. The middle of the disc, and you can see that here in sort of the blue, is like the jelly. That's what the shock absorbing characteristics of the discs are made of. And then the outside, or the purple part, is what's called the annulus fibrosus. And this is the portion that contains that middle pulposus section. As we'll discuss shortly, this is where you end up having a lot of pathology start. And as these discs wear down, they're more and more prone to injury. And injuries can occur even in young discs that have good water content. But as you can see here, they're 90% water. Basically, when any of these pieces doesn't work as it should, what happens? Well, obviously, we end up with back pain and the other related clinical pictures that occur. To start off here and give you sort of an overview of how big of a problem back pain is. You can see here that 80% will experience back pain at some point in their lives. This is actually the second most common reason for doctor's visits. And the cost is huge. It's $100 billion per year, and this is a few years old. So more than likely, this number has gone up. The good thing is 80% of people will recover in 6 weeks. So of all these people that develop back pain, many times it will get better almost on its own. It is the second most common cause for doctors' visits. The first, I talked about this before, but the first main reason is the common cold. So you can see just how many people will have this issue at some point in their lives. So how does back pain present? Well, there's the obvious ways it presents, but there are a lot of different ways that back pain will show up. Go to the next slide. There's a lot of variation in the way that it presents. The way each person presents is different. It depends on what's actually causing the pathology and the pain and each person's specific disease process. It's nice when a person presents in a very typical or textbook sort of fashion, but this isn't always the case. And this is where a lot of the history and exam for the patient gives some insight into what's actually happening. And then further imaging as well as procedures can be used in a trial and error process to really figure out where the issue is occurring. And as you can see from this slide, there's a lot of different presentations for back pain. And I mean, most of us have experienced some of these in their lives. And you can see that every patient is a little bit different. Now, before we go on, I want to address some of the presentations that require immediate attention. The reason that these require immediate attention, these are called red flag symptoms, and they either suggest that there's severe compression of a nerve or a possible infectious process, or that the back pain is actually secondary to something else that's more serious and requires further workup. So if any of these symptoms ever arise, this requires immediate workup. So rapid or progressively motor or sensory deficits, where a patient is saying, last week I had a little weakness, this week I can hardly move my leg, or my leg is completely numb after about a week or two. If the pain is acute onset, like it happens after a very short period of time and it's getting worse, particularly in someone with steroid use, it's something that requires further workup. Obviously, if there's major trauma. Also, if you develop really profound weakness in your extremities. Then on the other end, if you have pain which is associated with fever and chills, we want to look into whether there's an infectious reason. Numbness in your groin or saddle region is another very important sign that requires workup, as well as loss of bowel or bladder function. And also if a patient develops severe difficulties with balance. Now that we've sort of talked about the cases that require immediate attention, let's talk about how pain typically prevents. So given how complex the spine is, there's a lot of different things that can cause pain. In many instances, it's very difficult to pinpoint one specific pathology that's a definitive cause of the pain. Oftentimes, physical exam findings are not completely specific, and imaging reveals multiple issues, particularly in older patients, where there's not just one thing going on, there's multiple degenerative processes going on in the spine. So this really necessitates a methodical and stepwise diagnostic plan. This can consist of further testing, such as imaging, EMG testing, as well as diagnostic blocks. So as you mentioned earlier, 80% of back pain will resolve with conservative care. And by conservative care, we mean things like NSAIDs, physical therapy, and basic injections such as trigger points. And that's because the majority of back pain is caused by muscular strains. And these are things that usually heal just over time with bed rest and conservative care, as well as basic interventions. Because myofascial pain makes up such a large component of back pain, most of the time when a patient presents, we won't jump to imaging immediately. Most primary care physicians will not generally order diagnostic tests in the first week of 6 weeks of care. They'll just suggest conservative care, as we talked about. So the majority of these cases will resolve on their own. But there are clearly exceptions to this. For instance, if the pain is clearly radicular, it's going down your leg, for instance, in a very clear dermatome and causing weakness. That may be an indication to order imaging earlier. But generally, we give it some time, do some conservative therapy. That being said, by the time I see a patient, most of the time they have imaging done because they've already done the conservative care. Now, as I alluded to earlier, disc disease is sort of at the heart of the majority of back pain. So degenerative disc disease is a general term, and this essentially encompasses all disc pathologies. You'll often hear the term disc desiccation. This simply means that the disc is losing water content. The disc is primarily made up of water, and as that water content decreases with age, the disc becomes more fragile. The disc becomes less compliant or squishy, and is a higher risk for bulging or herniating at that point. As well as when the disc loses its cushioning capacity, it starts to transmit force to other parts of the spine. Although herniated and bulging discs are often used interchangeably, they're actually different pathologies. A herniated disc is a disc in which the fibrosis, the fibrotic outside of the disc is actually violated and the pulposus is coming out of that area. So the inside of the disc is extending outside of the fibrotic outside. And in terms of a bulging disc is when the actual anatomy is intact, but it's just bulging out. That being said, practically, it doesn't usually make much difference, except that a bulging disc tends to not really cause much pain, versus a herniated disc can actually cause discogenic pain. Discogenic pain resolves on its own, nonetheless. And the next slide, you can see. Did we actually skip one of these? Yeah, we just in the next one we see where there's a herniated disc here. Yeah, this is a slide, and you can see where the herniation itself is causing a problem. This is the anatomic abnormality where the herniation is now pressing on a spinal nerve, and this is what leads to your typical radicular or sciatic pain if it's in the lower extremities. In terms of radiculopathy refers to that previous image, and that's where a spinal nerve is being compressed as it exits the spine. This compression can occur for various reasons, including the herniations, bulging, as well as spondylolisthesis, which is slippage of one vertebral body over the other, or hypertrophy of the facet joints. All of these conditions essentially are just narrowing the hole where the nerve comes out. This results in compression of the nerve. In terms of when you do get a nerve compression, clinically, we can oftentimes figure out where the nerve is being compressed even without imaging. And most people have seen this image before. This is a dermatomal map. Dermatomes are the regions on the body where each spinal nerve supplies sensation. And this can, like I said, initially provide a very good clinical indication where the structural pathology lies based upon the patient's symptoms. Now, everyone doesn't follow this map exactly, but this gives a good starting point when you first see a patient, even before you get the imaging. So we were just talking about radicular pain, and radicular pain generally occurs when a nerve root is being impinged on, and that usually occurs in the neural foramen, or the holes on the side of the spine. Another canal, or the central canal, which is the canal going down the middle of the spine, can also be narrowed and cause other problems. This is called spinal stenosis. So as we talked about an extreme example of this, which was cauda equina, which results in weakness, bowel bladder incontinence, or in the cervical spine, this can result in cervical myelopathy. And these are both situations that require immediate attention. However, in less severe cases, this can cause back pain, which is dull, deep, and throbbing, and that extends into the lower back and buttocks. Typically, this pain will get better with leaning forward or resting, and gets worse with walking. This pain is very typical of both neurogenic claudication, or narrowing of the spine, as well as the vascular symptoms. So you need to really tease these symptoms out and fully evaluate the patient to make sure it's not a vascular issue. And in the cervical spine, this sort of narrowing leads to clumsiness or issues with balance, weakness in the upper extremities. So those are all symptoms that suggest the spinal canal or the central canal is being narrowed. So how do you treat this pain? Well, not only for this pain, but for almost all pain, my approach is typically a multidisciplinary approach. And what I mean by this is I don't rely on just one modality, such as injections or medications. Rather, I use a conjunction of all of these modalities to achieve pain relief and restore function. Function is generally my endpoint. Pain scores are an important part of documentation. However, functionally, that's what I really look at it. By comparison, function is a relatively objective benchmark which can be measured. For instance, a patient tells me they can walk 2 blocks, whereas before they can only walk half a block. That's a lot more useful to me than a pain score. Pain scores on the other end, are hard to quantify. I mean, even within a single patient, the pain score is affected by many factors and changes from day to day, it's difficult to actually accurately measure, although they do provide some value. So moving on to types of interventional techniques that can be used to control this pain. This is an illustration of an epidural steroid injection. Injections can be a very effective way to treat the symptoms and increase functionality. This is an example that's commonly used. I'm going to the next slide, which shows a specific example. This is an example of a transforaminal or selective nerve root block. In this type of injection, if we know exactly which levels are causing the problem, we can approach those nerve roots directly. You can see this is coming from the side or the neural foramen. This is in opposition to the next slide, which shows an interlaminar injection. An interlaminar injection is going right into the middle. It's a more generalized injection. This is typically where the labor epidural is done. It's not done along the nerve root. And this provides a more generalized, more diffuse spread of medication. So depending on the patient, there are multiple approaches that can be had in order to help reduce their pain depending on their pathology. In terms of other types of back pain, facet arthropathy is another leading cause of what's called axial low back pain. Facet arthropathy is just another word for arthritis of the joints in your back. So these facets in your back are typical joints. They have a synovial surface, they have fluid in them, and they're just like any other joint in your body, such as your knee or your elbow. This degeneration or pain in these joints typically causes axial pain, which doesn't radiate to the legs. It's typically restricted to the spine. These are the symptoms that typically occur, and these are oftentimes pain that's worsened by twisting, leaning back, or extension. And the pain, especially in the low back, can radiate from the mid-back into the upper buttocks. The next slide will show how the pain radiates depending on the level. You can see in both the cervical spine as well as the lumbar spine, the pain doesn't always radiate where you intuitively think it would. And so you have to keep this in mind anytime a patient has low back pain, and even some upper leg pain, that this could be due to facet arthropathy or pain coming directly from the facet joints. In terms of treating facet arthropathy, this slide illustrates what's called an intra-articular facet injection. And this is where you inject a combination of local anesthetic and steroid directly into the facet joint, similarly to a knee injection or any other joint injection. This brings down inflammation and can significantly improve the level of pain and functionality for the patient. This allows them to do physical therapy and other more restorative functions. More commonly, though, than this procedure is something called radiofrequency ablation, which I'm sure most of you have heard of. This is a procedure in which the nerve is very precisely heated with a needle or a probe. It's very similar to just an injection, but then the nerve in this situation is lesioned very precisely. And this provides much longer lasting relief of the pain. This is probably one of the best procedures that we can offer because of the longevity of relief. I have patients that get a number of years of relief from this procedure. Moreover, it allows them to really rehabilitate during this period of time with aggressive physical therapy and strengthening, which helps fix the underlying condition. Some other causes of axial or low back or neck pain are vertebral body compression fractures. And typically, this pain will be acute in onset. It may be preceded by a fall or trauma, and it can be recreated by pressure on the area. So just pressing on the back will oftentimes create really severe pain. There are multiple risk factors that predispose a patient to this. You can see in the next slide that there are oftentimes postmenopausal women over the age of 55, people with low bone density, which kind of go hand in hand, people with thoracic kyphosis. Another thing to keep in mind are patients that are on long-term glucocorticoids, such as patients with respiratory disease or COPD who are often taking steroids for long periods of time. They are almost always osteoporotic and at very high risk for this. So what we can do for this interventionally is something called kyphoplasty. Kyphoplasty is a procedure in which we access the vertebral body through a cannula, and a balloon is then placed through that cannula, which restores the height, makes a cavity within the bone. This is then filled with bone cement and restores the strength of that compressed vertebral body. The nice thing about this procedure is that it provides immediate relief for the patient, and it can be very effective in terms of getting them up out of bed. Now, the main indication for this is to reduce pain, not necessarily to fix the deformity. But that being said, some patients who sustain vertebral body compression fractures have so much pain that they can't even get out of bed. And this can be a good procedure if the pain is really severe.